and you're in the area, we're in the fancy looking research building that's on site, and we'd really love to speak to you about your ideas for research or how you can use the research in practice. So please do get in touch after this session. And without further ado, I'd like to hand over, I think, is it Jenny or Daisy first?
So I think it's going to be Daisy, so I'm going to just stop sharing my slides because I think Daisy's got her own slide set. And I just wanted to let everybody know that I've started recording the meeting, if that's okay. I think it's valuable to capture this, and other people who've not been able to attend today will probably love to hear what you've got to say. So if that's okay with everybody. So I'm just going to stop sharing for Daisy.
Thank you. Can you see those slides? That's great, thank you. That's great. So hi everyone, thanks for having me today. My name is Daisy Halligan and I'm a research fellow. I'm currently based in the PSRC Decluttering Safely for Safety theme. So just to give you a bit of context about the theme of research that I currently am based in, we carry out research that tries to reduce the burden of unnecessary practices on healthcare staff. So we are therefore really interested in identifying and stopping practices that don't actually improve the safety of care. Such practices can be referred to as low-value practices. The practice of de-implementation, which is the process of systematically removing low-value healthcare practices, has historically focused on stopping overprescribing, reducing unnecessary surgeries, and reducing unnecessary diagnostic imaging and screening. In this theme, we are more interested in the concept of removing low-value practices that contribute to safety clutter, which refers to the accumulation of safety procedures, documents, roles, and activities that are performed in the name of safety, but don't contribute to the safety of operations. It's therefore hoped that by removing safety clutter, we can free up time and resources that could be alternatively spent on more effective care and thereby can improve safety. So today I'm going to be speaking about a study that we carried out as part of this theme that focused on double checking of medicines, and just because this has been identified by previous research to be potentially low value for patient safety. So double checking, for those that don't know, is a practice that is widely carried out in hospitals to try and prevent medication administration errors. It involves two nurses independently checking several aspects of a medicine before it's administered, such as ensuring that it's about to be given to the correct patient at the right time, and it's the right dose and the right route. Recent literature has reported that there is insufficient evidence that double checking is actually effective at preventing medication errors. Because it's carried out on such a large scale, it takes up a lot of nursing time, which costs a lot of money. And this time could be justified if the practice was effective at preventing medication errors, but no such evidence exists. Some studies have actually found that not only does double checking potentially waste staff time, but it can also harm patients by delaying administration of critical medicines. And it's not really well understood how double checking became established in UK practice. And this can be seen in the Royal College of Nursing asserts that there is no regulatory requirement for double checking except for with intravenous drugs and medicines that require complex calculations. It's just important to note that there are two drivers for the double checking of medicines. One is to reduce medication administration errors, and the other is to prevent diversion and misuse of controlled drugs like opioids and benzodiazepines.
Daisy, could I just stop you there? Sorry, are the slides supposed to be moving on? Because we're still on the slide with the photos of us, and I just didn't want you to be...
Oh, thanks, Rebecca. Can you see the methods one now?
That's we can, one. Brilliant.
That's great. Thank you so much. So yeah, and the study that I'm going to be speaking about today only focuses on the type of double checking that would aim to prevent medication administration errors. So I just thought it was important to point that out. So despite the lack of regulation that underpins double checking, we understand that many hospital trusts have assimilated double checking over the past 25 to 30 years in response to recommendations from the investigation of increasing numbers of medication administration errors. There's currently no national picture in England of the extent to which acute hospital trusts stipulate double checking and how closely double checking is perceived to be conducted in accordance with these policies. So we therefore carried out a study that aimed to address this gap in knowledge by using two different methods. We firstly circulated an online survey link to a national network of 123 medication safety officers based in English hospitals. This survey comprised 10 different questions that focused on participants' perception of how closely double checking is perceived to be carried out in accordance with policy. We also sent freedom of information requests to 118 English NHS acute hospital trusts, asking for all policies underpinning medicines administration, such as general medicines policies and specific policies such as intravenous and paediatric medicines. So in terms of the survey findings, we found that in response to the question, in practice, how closely do you think the checking of medicines adheres to policies in your trust? The most frequently selected answer was some of the time, which was 33%, with only 4% of responses saying that it is always carried out in accordance with policy. In terms of the policy findings, we received policies from 94 acute hospital trusts, which is a response rate of about 80%. And we were able to extract relevant information from 82 of these policies. The table on this slide reports the percentage of trusts whose policies stipulated a double check for specific medicine groups. So from this table, you can see that there's a lot of variation between trusts in the groups of drugs that they require double checking for. Additionally, we found a lot of variation between trust policies in the way that they described how a double check should be carried out. So, for example, only 63% of all policies mentioned that the double check must be conducted independently, and only 26% of all policies provided further detail in either how to conduct a double check or the importance of conducting a check independently. So, to conclude, the findings from this study demonstrate that double checking policies vary considerably between trusts, and that medication safety officers perceive that it's common in practice for double checking not to be conducted in accordance with policy. So therefore, research is needed to understand if double checking is effective at preventing medication errors, and if it is, the exact circumstances in which it is effective to facilitate the standardisation of double checking policies. Identifying circumstances in which double checking is ineffective may lead to the removal of some existing policies, which could reduce nurse workload and free up time for patient-focused care. And this evidence has fed into a programme grant that Rebecca is leading on, that's starting at the beginning of next year, which will aim to test if reducing double checking of medicines reduces costs without increasing patient harm. Thank you. I'll stop sharing my slides.
Thank you very much, Daisy. So I'm just going to reshare slides because I'm going to be, I think, moving to here from Jenny Murray. Should be coming up live just now. And Jenny, are you able to take control? Yes, yep. Brilliant. Right, over to you.
Thanks very much. Hope everybody can hear me okay. If the slides don't move on for any reason, please do interrupt me. So yeah, thanks for inviting me to speak today. I want to talk about patient involvement in patient safety. And in particular, I want to talk about older people, age 75 plus, and their experience of care transitions. So I'm hoping that's moved. Yeah, great. So first I want to pick apart the title. So there were a couple of words that were in orange up there, and it's important to set the scene for these for the rest of the presentation. So the two key things that I want to talk about, first of all, are patient involvement, what that actually means or how we understand it, and then care transitions. So patient involvement is essentially about the work that we all do every day to manage our health and well-being. So that might be asking the right questions. It might be taking medication. If we've got certain symptoms, we might go away and do the dangerous Dr. Google, and we'll keep to appointments. And basically, sometimes situations arise whereby the work that we do isn't enough and we need other specialised work, and that's when we get hospital readmission. So when we talk about involvement, it's more than something that you might see or is conceptualized as you enter, say, a hospital, where you see things like on revolving doors, patients are at the centre of everything we do. Obviously, patients are at the centre of everything we do, but involvement is something fundamentally different, and I hope that that explains what it is in terms of work. So why are we particularly interested in patient involvement in terms of patient safety? So everybody will have heard this a million times before. Patients are the only people that are present throughout the whole journey, and that's certainly true. So there's continuity thing there, particularly when we're thinking about transitions between spaces. Patients are willing, as far as we know from the evidence, to be able to support patient safety depending on what it is and depending on the circumstances for the patient. Patients can support system resilience. So the example that I gave you before, for example, taking medications, but also checking medications, you can avoid errors and harm, which lead to harm and cost for patients and also for the system. And it's a low cost approach. And we know from evidence that some form of patient involvement, although it's not necessarily been fully picked apart what that is, sometimes it's called education. So, but some form of patient involvement leads to better outcomes for the patient. So this is the rub here. So basically the things that I talked to you about before in the slide about what we do on an everyday basis feel intuitive, feel like the right thing to do. But when a patient is admitted to hospital, that sort of intuitive way of being and involving and doing your work isn't intuitive. And sometimes to some extent, because in hospital it's an institutional setting, it's not necessarily always permissible to be involved in your care. And also it's not always acknowledged. And there's a moral imperative really about supporting patient involvement, but also a need to do that. And we've got some strong voices out there that are really supporting patient involvement and patient care. And in the NHS Patient Safety Commissioner strategy for patient safety, there are three key parts to that, and one is very strongly about amplifying patients' voice and empowering patients to be involved in their care. So the other, that's patient involvement, and I hope that's clarified what that means in terms of how we see it. The other area that we want to talk about that's important to this presentation is the concept of transitions. So what is a hospital to home transitions? And this is the particular area we're talking about. So we've dealt with patient involvement. We're talking about hospital home transitions and then also older people. So at the beginning of our work, we were really sort of interchangeably using, I think, a little bit the word discharge and transitions. And really, when we talk about discharge, we're really talking about a point in time. And when we're talking about transitions, what we're talking about is the point at which staff and patients potentially talk about getting ready to go home. So that could be, you know, a week or a few days before going home. And then it's that period of resettlement back into the home when people are trying to gain confidence again, trying to get their strength back up and establish a routine. So it's really a sort of phase rather than anything else. Why are we looking at patient involvement? You know, is it a problem? What's the problem with transitions? And there are some problems. So we know there's this break in continuity that I've already mentioned, and that 1 in 5 patients can experience an adverse event at the transitional period. And that we know that approximately 62% of these are avoidable. And when we look at older people, we know that hospital admissions are they increase quite rapidly in the over 75s, and that approximately 19% of older people will bounce back into hospital within 30 days, and that approximately 30% of those are thought to be avoidable. So what we're interested in is avoidable readmissions, not unavoidable ones, because those, of course, are the ones that are appropriate. So what happened around, I think it was 2015, probably 2016, was that there was a discussion with a forum of older people to explore what their experiences were and what they felt was important in terms of their care transitioning in and out of hospital. And they felt this was really important. So there was a team of researchers led by Rebecca, who put in for funding to NIHR and were successful to obtain a programme grant. And back in 2017, we started this work, and there were 6 stages to this work. So some initial scoping work, followed by some interviews with staff and patients and their family members, moving through to developing a measure of experience of patient safety, because at that time there was only one and it was based in the US. And then what we wanted to do was see what we could do about this problem, see what we could do about these avoidable readmissions for older people. So we worked with a group of people to co-design an intervention. We ran a feasibility trial, and then we did a cluster randomized control trial. And the second half of this presentation is going to talk mostly about the cluster trial and what we found. The very first part of this work was involved speaking to patients. And when we spoke to patients about their experience of going home and of being in hospital, what they effectively told us was being in hospital is maybe not quite as grand as this, but a bit like being on a cruise ship, insofar as they would come on board and basically everything would be done for them, which, you know, is really important when you're unwell. But at that point, when people are thinking about going home, that there are challenges that presents. So basically, the discharge process is actually really rapid, and sometimes it's quite unpredictable. And so what happens is that there's a handover of care back to patients quite suddenly. So they move from this cruise ship experience of being done for to Mrs. Jones, here's your discharge summary and here's your medication, and we'll see you. And what happens is that basically patients and families go from 24/7 care, where they're really cared for very carefully, to managing care all by themselves. And that can lead to a sense of abandonment and also anxiety. And basically what we see as a real consequence of this process, starting right with the cruise, right through to the dinghy, is that because of the way things are done in hospital, there's risks that are created in hospital. So patients having their medication managed for them, not moving around, for example, that actually creates a risk in hospital, but then that risk is actually received and experienced at home. And this is what staff don't see, the hospital staff don't see, but the patient experiences. So this is a really horrendous diagram. You don't need to read the detail in here. Basically, what this diagram points out is the red circle indicates all the kind of, I mean, this is sort of telescoped up, but the red area indicates all the work that staff do in the hospital. This green circle here, or oval, is the handover point. And then there's a handover to various people. And it's this yellow circle that we really want to acknowledge and look at. And this yellow circle is the work that patients then take on once they've been discharged. And the critical thing here to think about is at the hospital end, there's no yellow, as far as we could see through our observational work and through our interviews. But that is handed over, and this handover point is really important because it's not generally acknowledged. So what we did in thinking about what do we do about this problem of high levels of avoidable readmissions for older people, and we looked into this to see what tasks patients take on, because often they sort of reflect the tasks that they did before they came into hospital. And when we looked at these, this is what we found. Patients are obviously managing their own health, which is a huge category. They're managing their medications again. They're managing activities of daily living. And then if there's an issue, they need to be able to escalate care. And what we wanted to do to help to resolve this problem was we wanted to think further back upstream into the cruise ship to really see if we could get patient involvement work, if you like, to help patients know more and do more. In these particular activities that they were going to be responsible for when they went home. So what we're talking about is not fit for discharge, but to be fit for transitions. So we went to a team of people, staff and patients and families, and we co-designed an intervention. Obviously, there was a lot to this, so I'm just giving you the sort of like brief summary of what we found. So basically, we developed material to enable patients to effectively kind of reach into the system, to enable them to be involved. So we developed a patient booklet with questions that they might want to ask, and with notes area. We developed a short film based on our interviews. So this is based on people's real experiences. And then we developed a nice advice sheet for managing at home. This was originally a patient-friendly discharge summary, but we came unstuck in lots of ways with that because it became quite complicated, and we sort of trimmed it down into an advice sheet for managing at home, which was tailored at the ward level. And then we developed some posters. And alongside that, we developed a training package for staff, because what we're effectively trying to do is not only try and shift this dynamic where it's not intuitive to be involved and do work in hospital to something that is more intuitive. So we're trying to shift at the patient end of things to change the way they think about who they are in hospital, but also through the training, shift the way staff think about how patients are, to encourage them to be more empowering and support patients to reach in and to do the work. So after a lot of sort of design work and feasibility testing, we basically wanted to take this out to a full-blown trial. So our plan was to assess, take this out to a trial to a number of hospitals, and to assess 30-day unplanned hospital readmissions as our primary outcome. So we wanted to see, we couldn't measure avoidable readmissions, but it's quite challenging to measure that, but we thought we'd look at something sort of vaguer, which was just broad brush unplanned hospital readmissions. And we were going to get that from routine data from a very, very large sample, so over 5,000 patients. And then our secondary outcomes that we were really interested in were patients' experience and quality of transitions. So when I showed you the road diagram, one of the things I mentioned was a measure of patient experience and quality. And that's something we brought into this. And we were going to measure that 7, 30 and 90 days. And our plan was to recruit 1,000 patients. And that was going to be in a nested study. And we were going to also look at readmission data at 60 and 90 days. And then alongside this trial, we were going to do some health economic analysis. We were going to assess the fidelity. So was the intervention developed in the way that we anticipated? And then some process evaluation work whereby we tried to unpick and explore how the intervention was working and was it being delivered in the way that we anticipated. Our plan was to deliver this across 11 trusts, NHS trusts, and 40 wards. So this was due to start in 2019. Everybody knows what happened then. And things got very complicated for a very long period of time. But we're really pleased with the outcome because we did actually manage to get 11 hospital trusts, and we included 39 wards. There was also clearly a lot of work that went into that. And it was very, very difficult for staff to be on board with this, but many hospitals were really keen to do something really positive. We delivered training to 96 staff across 18 intervention wards. So on the wards, we had the intervention being delivered as usual care, so all patients would get it. And then we had wards that carried on without the intervention. And we actually recruited almost 5,000 patients to the routine data. So that was our primary outcome of unplanned hospital readmissions. And then to the follow-up study, so looking at patient experience, we involved 35 wards and we recruited 613 patients. So that was just over half what we anticipated. There were incredible challenges to doing recruitment during that period. And if anybody was involved in research during that time, they'll understand that. And we had to make quite a lot of adaptations quite swiftly. And so this is what we found. Apologies for the bullet points. So a brief run through. So just to set the scene, the thing that we put in was changing patient involvement in transitions, but transitions are really multi-component interventions and there's an awful lot going on. So we effectively really dug deep into one area. during a very difficult time. But what we found was that the odds of a patient readmission at 30 days wasn't significantly different in the intervention group versus the control group. And it was the same on 60 and 90 days. So 1 month, 2 months, and 3 months, but all were in favour of the intervention. And when we looked at the total number of admissions, so the first one is really about Joe Bloggs himself. What's the chances of him being readmitted? The second one is the total number of readmissions, basically all patients. And we found that at 3 months, there was a significant decline in readmissions, so 13% lower. So that was significant. So we're really pleased about that we found some finding. And this is very much in line with other transitions interventions that have been done in older people. And those previous transition interventions have actually been multi-component, whereas ours is only effectively a single component intervention. We also found when we measured safety events, so that's through the measure that I talked about in the earlier slide, that there was a significant reduction in safety events at 30 days, but at not other times. So we've got a reduction in safety events at 30 days, and then something's happening at 3 months. And we think the two things may be connected, but we've got no real evidence to understand that pattern. We think that the intervention may be cost effective. Now, I've already mentioned that we were trying to conduct this trial, not in the thick of the pandemic, but certainly in the long tail after that, when services were all over the place. And we found that our intervention was delivered not as well as we had anticipated. So it's interesting that despite the low to moderate fidelity, we still find some effect. And we also find that up to 88% of people find the intervention useful to very useful. So there's some really positive news coming out through this. And ultimately, what was our learning from this? Well, I've already talked about putting in the training to support staff to reach out to patients, to involve them, and also encouraging patients to move from this non-intuitive, passive state, if you like, of not being involved in their hospital care to be involved. So we understand now that it really needs both patients, families, and staff, and therefore it requires a culture change. We know that staff really like the concept of the intervention. When we were delivering training, we could really see that. We know that there is a tension, I've already alluded to this, but there is a tension by encouraging staff to encourage patients to do more, that actually there might be some risk challenges in that. So encouraging people to get up and moving, particularly older people. But what we're trying to do is balance risks. We're not trying to completely wipe out risks. We're trying to balance risks so that they're managed in hospital, but equally that management transfers over into the home. And that patient involvement, as I mentioned before, is just one of several elements or components in care transitions. And what's next for this piece of work? Well, the intervention is freely accessible. One of the things we would obviously be concerned about is that if the intervention, say, in terms of the booklet, the advice sheet, and the film is just downloaded and used, if it doesn't sit alongside training, then it's only doing half of it. We've published really widely on this, and we think we've moved the science forward on patient involvement and patient safety, and certainly in terms of transitions interventions. We were having discussions with sites who were involved in the trial, and some are already making changes as a consequence. So that's really encouraging news. We're going to develop a training package. We're in discussions with the Improvement Academy. We need to think about the inclusiveness of this intervention, and work needs to be done on that. And that we really know now that patient involvement in patient safety is pretty critical. So I just want to thank you, and thank Rebecca, of course, for leading this brilliant piece of work, and the rest of the team.
Brilliant, Jenny. I've written down a few notes and things, and I think we'll have a little bit of time at the end of the next presentation after Ange, with regards, I think, some things that people might like to ask. So thank you very much. Just going to reshare. Okay, so Ange, I think you should have the ability to be able to present.
I don't have the Oh yes, here we go.
There you go.
I've just got it from the very start there, Liz.
Okay, so you need to go to slide, I think is 22.
Right, just flicking through.
Yeah, 23. It's a nice recap for Jenny.
Can you see that?
Yes.
Great. This afternoon, good afternoon, everybody. I'm Angela Grange. I'm the lead nurse for quality and safety research here at Bradford Teaching Hospitals Trust, and I've been working in patient safety, well, since it started here, really, 2006, when it was led by Professor John Wright, and now taken over by my boss, Rebecca Lawson. So I'm going to talk to you about opportunities for getting engaged in patient safety research, and that's really within the context of the patient safety research collaboration, which is hosted here at Bradford Teaching Hospitals. So I don't know if you are aware, but there are 6 patient safety research collaborations within England, and we are the largest. And the aim of these centres is to kind of develop innovations in patient safety, to look at developing capacity and capability for staff, and also to look at addressing partnerships and collaborations. And there's a web link there where you can have a look at what the patient safety priorities are nationally, and you will have seen that there's been a report just published today on that by Lord Darcy, so that's an interesting read. So the Yorkshire Humber PSRC, there's lots of acronyms in research, so forgive me for using those, but we're one of the 6 centres, we're the largest, and we're a collaboration between Bradford Teaching Hospitals and the University of Leeds, but we also have partners in the University of Bradford, Nottingham and Oxford. And I think we got the largest amount of money, 5.8 million, which we're spending over 5 years and concentrating on work in 4 themes. And so Rebecca is our director, Beth Ryland is the assistant director, and Jenny, who you've heard speak, is our programme manager. So do have a look at our website and you'll see further information about these themes, but just in a kind of nutshell, obviously our intention is looking at making care safer, and our values about doing that together, learning together. Equality, diversity and inclusion is a really strong thread through all of our work, and so we champion that, and we embrace complexity, and we value everyone's contribution. So there's a summary there of the 4 themes. So Rebecca leads the decluttering safety for safety theme, and you've heard Daisy talk about one of the projects within that. Beth is a lead on the supporting safe care in home, so that's looking at the benefits and risks of home care and looking at interventions to support patients and carers to manage care at home safely. We have a theme on rethinking safety intelligence, so that's looking at how we use information from soft intelligence to make improvements, how we look at integrating data, and how we use data to drive improvements in patient safety. And that is led by Dr. John Benn at the University of Leeds. And then we have Jane O'Hara, who works at Cambridge University, who leads the Safer Systems, Cultures and Practices theme, and also co-led by Carmen Craig, but I think he's at Nottingham. So I just wanted to give you an overview of the 4 themes, and they will become relevant when I talk about the opportunities for staff from underrepresented groups, particularly to get involved in our work. So the patient safety research collaboration here in Yorkshire and Humber has a strong theme on focusing on capacity development. So that's getting more people engaged in research and upskilling people on knowledge and skills in research. So it's about developing individuals, it's about developing our research community and upskilling people with knowledge, and also the ability to lead research as well in the future. So I'm sort of really going to focus on the second box from the left, which is about clinicians. I feel really passionate about this, about giving opportunities to clinicians that work in the front line to get engaged in research. But what you'll see in the other boxes, the other types of capacity building that we do. So also with researchers, we have a lot of PhD students that work with us, and then we've had safety equity fellows that have worked with us that are kind of linked in through the Bradford University, and we also have placement students from the University of Leeds on internships. So there are some kind of academic opportunities for clinicians, which is what I'm going to focus on in this presentation. And then all of our work is supported by representation from the patients and the public, and we have lay leaders that work with us, and safety equity is a theme that runs across all of our work too. I wanted to kind of focus my presentation on the opportunities for clinicians in particular to take time out to work with us in patient safety research. And we've had funding through the patient safety research collaboration to kind of test out a couple of schemes, and we've got 5 people that are working with us that have been successful in obtaining a patient safety research development award. And so we've got 2 pharmacists. We've got a nurse, Maria, from Bradford Teaching Hospitals, who works in infection prevention control. We've got a physio, Cordy, who works in critical care here in Bradford, who's got one of these awards. And there's also somebody from Bradford District Care Trust, who's a service evaluation lead. The 2 pharmacists that have been awarded these awards work at Leeds Trust and also in a primary care network. And these opportunities were, we had funding of up to £7,000 per applicant to bid for, to buy out their time to come and work with us within the patient safety research collaboration on projects within the 4 themes that I kind of highlighted before, but also an opportunity for them to develop their own ideas that have come from practice or patient safety challenges that they wanted to investigate. And I've listed there the kinds of activities that people can get involved in. And so we recognise that people can be at any point on their learning within research. So they may be complete novices and just dipping the toe in the water, or they may be people that have done a bit of research or improvement work and want to kind of develop that knowledge and skills further. So you might have an idea for a patient safety project or an improvement project. You might want to look up some evidence on a topic. You might want to work alongside an experienced research team member in our team. You might, research is a multi-professional activity. It's not done unilaterally. You need to work within a team, and sometimes you just need that time to find potential collaborators that you could work with. One of our applicants, Maria, from the Trust, is putting together an application for some research funding through the National Institute for Health Research, so you can use that funding to take that work forward. And the idea is it is about sort of supporting the individual and supporting their personal development. So we've got our first cohort that's going through now, 5 people, and we'll be advertising another round in early 2025. And this will be open to any NHS clinician that works within the Yorkshire and Humber region. So look out for that call. It'll be early in 2025, and we promote it through all our kind of social media channels and on our website. We have a current scheme out at the moment, and the closing date's a bit tight. It's the 16th of December, but we will be also running it again. And this is a kind of next step along, if you like, from that early kind of individual award. Again, this is an individual award, but it's about some funding that we got from NIHR. We got £180,000 to help, infrastructure funding to help with capacity and capability development for researchers. And this is to enable clinicians from underrepresented groups to buy out their time to actually prepare an application for research funding. The NIHR, in that slide, there's a lot of information there, but the NIHR runs so many schemes now. It's so different when I started my PhD in 1998, where there just was hardly any funding for nurses to do a doctorate, but now there are so many opportunities, and they've kind of restructured their offer to make it to simplify it, to make it easier for clinicians to navigate their way around. And so there's pre-doctoral, doctoral and postdoctoral funding, and these schemes are open for staff that work in health and social care, so even in local authorities. And we've got some funding to buy out time for these staff from underrepresented groups to have time to prepare an application for research funding. So there'll be up to £15,000 per applicant to apply for, which can probably buy out a couple of days a week to work on developing a research idea for an application for this kind of individual award. So the NHR recognise that that nurses, midwives, allied health professionals, pharmacists are underrepresented. When you look at the data on who's successful in acquiring research funding, those groups are least represented. So I think that there's a drive from NHR to kind of boost capacity within those professions. So this funding is open to those professional groups working in Yorkshire and Humber, including clinical scientists as well. But interesting as well, that it's also open to academic researchers who want to develop skills in a particular methodology. So you may be a statistician or a data scientist, for example, and you may be a nurse and midwife or AHP that works in the university sector, and you would still be eligible to apply for one of these awards. So as I've mentioned before, there's up to £15,000 to pay for salary backfill to release you from your current job to spend time developing this funding application. And importantly, they've included a budget for travel and for training. And if people have already applied for research funding, you'll know that patient public involvement and engagement is a really strong theme in funding applications, and we recognise that people need a resource to do some PPIE activities or EDI work, and so that's been included within this opportunity. And then importantly too, also a small budget for any reasonable adjustments for individuals. So that in order to apply, you just need to log on to the Yorkshire and Humber Patient Safety Research Collaboration website, and there's an online form to complete. We recognise that clinicians don't have a lot of time. We don't want it to be a really onerous application. So it's fairly straightforward and very much focuses around what your learning objectives are, how the money will help develop your career in research development. But importantly, you need to spend some time looking at the themes of work within the Patient Safety Research Collaboration, because your ideas need to link in some way to those themes. So if you're interested in applying, do apply, and then we'll shortlist applications and invite individuals for an online interview, which will be on the 13th of January. And it's a really quick turnaround because NHR has said we need to have awarded the money before March 2025. But we will be running the scheme again in April. But there'll be more awards this year than April 2025. So we want people to start after March on these projects, and it'll probably fund about 6 months of your time to work with us to develop that application. And so a successful output for us is that you actually get to submit an application for funding from this scheme. I just wanted to highlight as well, because I don't know how many people know about the Improvement Academy, which is hosted here at Bradford Teaching Hospitals Trust, but there's also opportunities for clinicians to engage in improvement work, and I expect that Liz probably plugs this in her role in QI, but there's a Future Leaders program where you can develop your leadership skills and improvement. You can also get some academic training you lead projects in patient safety across the region, and they're a year in length. And I've supported nurses that have gone for this scheme, and they've undertaken the Mary Seacole leadership training, but often they're medics that do this, but we have had pharmacists and AHPs. So keep an eye open for those opportunities, and I've put the link there where you can find out a bit more information. So I guess what I'm saying is there's a huge amount of opportunities, and if you want to find out more about any of these, just drop me a line, and I'm happy to have a conversation. Or if you're uncertain about whether you're eligible or need some support, just drop me a line, and I'm happy to support. This is just a slide just showing all our social media channels. So we have presence on X and on Instagram. We've got a YouTube channel. So I just wanted to put those all on one so you can access those and look at those at your own leisure and find out a bit more about us. All the patient safety research collaborations, the 6 centres, are part of a safety net kind of collaboration, and through that they run a series of seminars with some really exciting speakers and international speakers, and so you can subscribe to that and get newsletters through Safety Net and access the online seminars. So there's also another resource there. So I think that's it. Liz, that's the end of my presentation. I'd be happy to answer any questions.
Brilliant. Thank you ever so much. As I said, I just realised at the start of this meeting that I didn't actually introduce myself. So I'm Liz Tomlin, Head of Quality Improvement and Clinical Outcomes at Bradford. But I have to declare the fact that I know my colleagues, our research colleagues, very well as well from previous work and working within the teams. So, but it's just amazing and fantastic to see all the work and opportunities. It feels really exciting. I was just going to do a quick recap and then give an opportunity for people to ask some questions. I know there's some stuff that's been popping up in the chat, so I know Sophia's keeping an eye on the chat for me. So just to summarise, we've heard from Daisy around the safety decluttering. So again, I know that was some of the early the research findings, which is really interesting around, again, of course, variation of practice, not really kind of understanding whether the practices come from double checking and how sound it is. But I think we've got some colleagues who'd be interested to, as you said, if you share those findings. And I think that Sana, I know, who may still be on the call, I think she put something to the chat, and I think she's already directly emailed you with regards to some of the work as well. So that's fantastic. I don't know if there's anything that, Sana, if you're still on the line, or Lisa Jameson even, because we've been doing some really interesting work around looking at safety incidents. If they wanted to add anything at this point.
Do you want to add anything, Sana? She might have gone.
She might have gone. Lisa, is there something you wanted? I thought some, like, as I said, share some of the amazing work that you've been doing around the thematic analysis, again, of a quite large data set for our incident so highlights.
I can give a very brief summary. So medicines are one of our top 4 reported incidents, as you would expect. So they will be one of our piece of improvement programs. So we wanted to understand, what is it about medicines that are going wrong? So our starting point, and we are very much at the start of this program of work, is looking at our incident data and see what that has told us. So I did a thematic analysis of it, which took a very long time because I looked at almost 900 incidents from January of this year, when we went live on our new incident reporting management system, through to the end of September. And what that highlighted was, certainly with our administration errors and our prescribing errors, we make more errors associated with our injections, our infusions, our controlled drugs. So the next step is to really get out on those ward areas who are the highest reporters and try and understand a little bit about what's going on. We've got a working theory. It could be to do with interruptions that we want to test out. So yeah, so that'll be something that Sanna will be picking up in the new year, and I'm sure she'd be really grateful to be working with you, Daisy, on this as well.
Thanks, and I'm sure we'll be able to share perhaps some more sort of further insights with you and the team going forward as well. We also, is anything else, anybody wanted to have any other questions from Daisy? I'm just looking at Sophia. Oh yeah, that's just a message from Sophia on the chat. Is there any other questions for Daisy? Can't see everybody. Okay, so I'm just going to move on. So again, we heard from Jenny Murray around the patient involvement in patient safety and around specifically around developing an intervention for care transitions for our older adults who've been in hospital. And again, it's you know, fantastic to hear the input that patients have been involved in with regards to this piece of research and around trying to, as I said, amplify that patient voice. And really trying to get to grips to understand the issues around that transition period from discharge. And again, so some of the findings from the research which regarded the fact that the staff really liked the concept, but it still required a culture change in that conversation and involvement with our patients. And again, we recognise that balancing risk. We talk a lot about the interplay between managing falls and managing pressure ulcers, and that often that balance that we find on our wards. But it also links in really nicely with some deconditioning work that I know is going across the trust. So again, I'm really keen to share this again with our care of the elderly teams and relevant groups and teams. So Jenny, I'll be reaching back out again. I said it's great, that's free resources. I understand obviously the training, but again, I think this is a fantastic opportunity for us to think about doing something different and trying to either prevent readmissions and supporting our older adults safely back home. So again, I don't know if anybody's got any thoughts or comments. Doing a quick scan. But I was just going to say that I was going to share all the slides anyway, because I think, Angela, you finished again talking about all the opportunities there are around getting involved in research and potential funding for clinical staff, which is an amazing opportunity. So there's lots of information. So I will be sharing the slides set with everybody, so again they can get directly in contact with people and also sort of access all the links and the resources that you've included. And of course the improvement team were very happy to signpost, so get in touch with us if you wanted to know anything else or any other kind of information. But I just wanted a big thank you to our research colleagues who have come to present today. It's been fascinating, so again thank you very much. Rebecca, I don't know if there's any last comment that you'd like to add before I move on to our last section of the meeting.
No, just thank you to the brilliant presentations, and also it's clear there's some more opportunities for engaging with the trust as a result of that, and other trusts across Yorkshire and Humber. So thank you for inviting us.
No, our pleasure. So thank you very much. So we're just going to move on to the next sort of part of the session, which is really from thinking about the quality improvement team. So we sit within the quality team within the organisation. So we're really very much embedded and think very much around the patient safety incident response framework, and we're also involved with the Martha's Rule implementation. Martha's Rule, and actually how we're also supporting work around deteriorating patient and trying to improve care and outcomes for our patients. But we've got two very special members of the team who are both moving on to pastures new. So I thought it'd be a fantastic opportunity for Faye and for Lisa to perhaps just share some of the reflections while they've been working with us. So I'm going to sort of hand over to Lisa first of all. So we've got about 5 minutes or so. It doesn't seem very long considering the amount of work that you've done and actually been involved in, and the amazing contribution that you've given to the team and the organisation. And then I'll hand over to Faye. So Lisa, if I stop sharing slides, people might be able to see you as well.
Thank you, Liz. Yeah, so bit of background about me, I guess. I joined Bradford Teaching Hospital almost 4 years ago, so we're still very, very much in COVID. My background's pharmacy. I'm a pharmacy technician. Trained in acute, spent about 10 years working in acute in the 90s, early 2000s, but then moved into primary care and community care for 18 years. So me moving back in variety of roles in different organisations, medicines management teams, quality teams, and finally towards the end of my time in primary care, moving into quality improvement through medication safety and patient safety, and then finding improvement. So moving to Bradford for me was about an opportunity to see improvement from an acute trust, because it had been many years since I'd worked in an acute setting, and I was a very junior member of staff at the time. So Liz just asked me to reflect on that a little bit, I guess, and tell you what it's like working in a quality improvement team in an acute trust. So I wrote down 3 words. I wrote down learning, connectors, and privilege. And so the first one is learning, and my goodness me, I have learned so much in the past 4 years. We're in a really unique position in the improvement team, in that we almost have access to all areas. We get to work with so many different teams across the trust, and it gives us a bit of a helicopter view of what's going on right across the organisation. I'm not saying we know everything that's going on in every corner, but we know a lot, and we know a lot of people. So yeah, huge learning curve. I've learned stuff that I didn't even know that I needed to know until I was involved in a piece of work. But to do improvement properly, you've got to live and breathe what it's like for those frontline staff. So I've spent an awful lot of time talking to staff and observing work practices, and I feel that's really important, and something that we're quite skilled at in the quality improvement team. And because we do have this unique kind of helicopter view, actually what we are, we're the connectors within the organisation. We do a lot of connecting people. Oh, go and talk to pharmacy, they're doing a piece of work that's similar to yours. I know you're in radiology, but actually the 2 services aren't dissimilar. You've both got very transient patient populations. You touch most people that come through the front doors of the hospital, you know, and we can see those similarities. So we've done an awful lot of connecting people, and I think that's been a huge part of my role. And last, really, I've said privilege because it has been a real privilege to work with these very dedicated frontline staff who have genuinely wanted to make care better for their patient population. And to be a little part of that has been a real privilege. I think probably the proudest piece of work I've been involved in, and you've mentioned Cordy, and it's a pity she's not on the call, is the tracheostomy work. And I am getting quite emotional because I've done some amazing stuff, and it will be sad to move on, but I'm going to a new challenge, and hopefully I can take all that knowledge and connections with me. Thank you.
Thank you, Lisa. So no, it's not my job to make you cry, but if people don't know, I haven't met Lisa. She's done some amazing work, and absolutely the work you've done on the front line and making a real difference to patients' outcomes and the care, especially with the tracheostomy, and also the work we did with around worries and concerns and Martha's rule. You know, we've won an award from the HSJ, highly commended for that work for around the worries and concerns. So again, just a big thank you to Lisa for the last 4 years. You know, you'll be missed, and yes, and we hope you'll carry on your QI, habits of an improver, that curiosity that you've got, the questions, and the fact that we are, as you said, linking people together, bridge builders. So thank you. Faye.
Well, how can I follow that from Lisa? I'm not sure that I can. So I'm conscious there is some external colleagues on the call, so I'll just introduce myself. I'm Faye. I've been working with the quality improvement team on a fixed term contract for the last 18 months. I am a nurse by background, and I've been a nurse for about, I think I'm hitting somewhere close to 30 years at this point. I worked on the wards for a number of years. I worked in ICU for about 10 years. I even had a foray into research as a research nurse for about 3 years at Leeds, before moving over to Bradford and becoming an infection control nurse for about 8.5 years, which did include working through the pandemic, which was definitely a challenge. I think as a infection control nurse, you do actually struggle to try and do a lot of patient safety, a lot of patient improvement, because you're ultimately an IPCN because you do want to make things better. But unfortunately, I didn't have any quality improvement training when I was an infection control nurse. And I think even with the best of intentions, most of my projects actually failed because there was no sustainability within them. And I think I just found that really, really frustrating. So I found myself 18 months ago thinking, what can I do now? What can I do that's a new challenge? And I saw the job advertised with Liz and her team as the quality improvement manager. And I thought, right, this is the job for me. The last 18 months have been definitely, like Lisa, a massive learning curve. I've learned all sorts of things, not just about quality improvement, but about the hospital and about myself as well. I have learned all about the model for improvement and how to understand a problem properly. I've learned about how to set a smart aim and how to make it smart. I've learned about all the different QI tools and methodologies, from process mapping across to driver diagrams and fishbone diagrams. I've worked on lots of different QI projects, such as the blood culture improvement pathway and the hospital acquired pressure ulcer improvement project, which is one of our PSERF priorities at the moment. I've also had the opportunity, because Liz doesn't like us to sit on our hands doing nothing, to dip my toe into other areas such as quality assurance. I've helped out on the National Delirium Pain Audit and the End of Life Audit. I've also done a little bit of work with the patient safety facilitators around after action reviews and incident investigations and developing improvement plans for our staff, which would have been called action plans in the past, but now we like to call them improvement plans and use a PDSA methodology. I've also helped out with some service evaluation and also with some of the innovation team and with some of the new different programs that they want to trial at the trust around things like an interpretation service and a new rostering system for our trainees. I've managed to shoehorn in some training as I've gone in the last 18 months. So I've done some PSERF training, I've done the QSERV programme, which our transformation team run, which has been really beneficial to me. I've done some behavioural change trainings, and I think the Silver QI training through the NHS Leadership Academy as well. I've also done a lot of training myself. I've taught a lot of people about quality improvement. I managed to get hand hygiene shoehorned into that as one of our examples about how we can make improvements in different areas, and use that as an example for our staff within the trust. I've taught on all sorts of different leadership programs, the silver, the bronze, silver and gold. We've taught consultants, trainee doctors, junior doctors. I mean, it goes across the board. My biggest challenge was figuring out how to use an Excel spreadsheet, then how to get all my data into that and how to do my graphs, my run charts, my SPC charts. I mean, as a nurse, these things are never ever taught to you until you suddenly find that you're in a new role and you really need to know how to use them. So that was probably my biggest challenge. I've also learned an incredible amount from my team, from Liz, from Lisa, from Sophia, from Claire, from Zach and Caroline, and also a few other members like Atia and Beth along the way. I'm really going to miss the QI team. For me, I'll be heading off to Wakefield in the new year, so I'll be going to work in Spectrum Community Interest Company, which is based out of Wakefield, and I'll be visiting all the prisons in the north of England, and I'll be spreading the word not only about quality improvement but also about infection control as well. Like I say, I'll be very sad to leave the team, and I'll be very sad to leave Bradford as well, because I've had 10 very happy years here, and that's really me in a nutshell. Thank you all very much.
Fantastic. Thank you very much, Faye. Again, so, I mean, Faye came into the team from the IPC team, didn't you? And I said it was a steep learning curve, but the fact that you were able to, I threw you all sorts of little curveballs, but you always picked up the challenge, and
you gave me no choice, Liz.
you've been fantastic. So you've had a full range, and you've supported the innovation work as well. So again, we were trying to make sure we bring a bit of rigor to the testing out new innovations, wrapping a QI lens. I don't know that that's quite the right metaphor of wrapping a lens. I don't know if you can do that, but do you know what I mean? Making sure that we provided a bit more of a robust way that we were testing these things out. So again, but a massive thank you, Faye, who came in, and I managed to keep for a little bit longer. But again, I know you've got an exciting job that you're going to. So again, so thank you very much to Lisa and to Faye for all your hard work over the last few years, where you'll be again sadly missed. So thank you. So with that, I don't think, as I said, are there any other, Sophia, is there anything else that anybody's from the chat wanted to comment upon? So we are going to try and make sure our improvement network again is sort of up and running. We're trying to probably do it sort of quarterly next year. We're working again with the transformation team, who are just currently in sort of a process of development and sort of reorganization within the organization, so that we actually come together in a bit more of a unified fashion. But I hope it's been really useful. We'll be sending around the slides. I'll send you a little QR code for an evaluation. It's always worth getting feedback from these meetings, so we'd really value your thoughts and comments. But thank you everybody for coming and taking the time to listen to our colleagues, and I wish you all a very happy, merry, festive season, Christmas, and yeah, look forward to seeing you all in the future, new year. Anyway, take care, everybody, and thank you again.